Hi, everyone. Welcome to the Silvates podcast. So, today on the podcast, I have Mark Archer join me. And the reason why I've been trying to get Mark on the podcast for a while is because Mark works in a pain service as a physiotherapist. Now, Mark has a huge amount of experience behind him. He's been working as a practitioner for the last 22 years. He's worked in MSK services, in pain services, and more recently as a pain advanced practitioner in physiotherapy. So, thank you so much for joining me today, Mark.
It's my pleasure. Thank you for inviting me.
And it's true, I probably haven't done your bio very much justice, but you do come with this huge array of experience. And that was so evident when we were working together in the pain service. Um,
I, I think I've had a rather lucky career in that respect. I was subject to uh, quite a bit of psychological oversight early in my career, which sort of broadened my perspective from when I was a junior therapist. Really, I did a stint in the NHS and then a stint in private practice, but more recently, like you said, back into the NHS for a stretch now, which is where we met.
and I think that really comes across, especially when I worked with you, is that huge underpinning of the psychological processes, which for me really marked the difference between how you work within sort of a more musculoskeletal type of service rather than a pain service. And for me, that was such a revelation because that's what I was looking for years is how do I apply all these concepts that I've learned and taught as a lecturer and I think you were able to bring that together really well.
Yeah, and it's been a real process of trial and error. I suppose I'm not the most educated with the letters after my name sort of practitioner, but I've seen a lot of patients, and I think a lot of my early experiences um, left a really big gap in understanding what I was seeing clinically, what I was doing clinically, and then the outcomes. I think one of the earliest experiences I had was um, treating somebody with a shoulder thing. I did my beautiful NSK assessment, put together a lovely sort of graded exposure strength training program, did some manual treatment and some sort of adjustments to the shoulder joint, and she just got better perfectly in about a 6 week cycle. Um, and then at the end, she said, "But I don't understand how I was getting better. You were treating my right shoulder, but it was my left shoulder that was in pain." And I was just left completely stumped. I was thinking, well, what on earth is this all about? Why is this person getting better? And there's lots of different things that we can think about in that context, because there's obviously the natural history of the condition, which is I think uh, is not thought about anywhere near enough in our line of work. And most things get better so long as you get out of the way of the potential healing problems. But I was also thinking about the amount of connection and security and reassurance that you provide as a clinician. And I remember being sort of supervised by my psychologist colleague back then, and that's exactly what she was saying. Is that maybe you're just holding space and creating this safety so that people can allow their nervous system to calm down. And that really has informed my practice a great deal. I think if I was to put a headline to the way that I work, it's it's how is it that we create connection and safety.
I love the way you describe it because I find it really hard to explain to people what we do in a pain service. And I'm just going to redirect them to this podcast and listen to you for an hour because that just made much more sense than I could ever make it. Um, I wonder if, and I know that pain is such a complex and multifactorial sort of topic, but I wonder if you could sort of talk to me about sort of framing how pain works in our society or doesn't work in our society.
Yeah, It's such an interesting question because we can go extremely broad scope in our understanding. I think we can kind of step this out gradually. We can experience our, pain is sort of this experience within our body that locates within our musculoskeletal system that may sometimes be related to some degree of tissue damage, and so that's our sort of our nociceptive state perhaps, and we can step this out through an understanding of sensitizing processes. I mean, that the first step out is thinking about the psychological layer, the thoughts, the feelings, which can serve to compound and amplify the sensitivity within our nervous system. I always think about it as a series of sliders going up and down. And that was taken from Lorimer Moses' work. The sliders in the brain that amplify the signals. But then we broaden out even more into the social context, and I think this is an area that I've become more profoundly interested in, more over the last maybe 3 or 4 years, because I'm starting to believe that the soup that we swim in is perhaps even more important than any of the other features that I mentioned. Clearly, the physical state is not sufficient. The psychological state is important, but the social context is just gigantic. I think working within the pain service more recently over the last few years, I've been exposed a great deal more to the depths of socioeconomic imbalance and deprivation and sort of mismatching need within society. Um, and I think for me, one of the biggest, is it a frustration? I suppose it's a frustration, is not feeling like I'm not able to really touch that. It's almost like we can sort of pull people in, and certainly for myself within the clinic room, I can create this environment in which there is safety and connection, and so you get that security within the therapeutic environment. I know for sure that the therapists that work within these services do exactly the same thing. We're awesome at it. This is why we're paying people. And so there's a natural tendency to look for connection, to look to create safety and to hold space well. Um, but then we drop them back into society, right? They're straight back out there um, into the soup that's that may have the source of their trauma in. Then I remember one man particularly um, who long standing pain difficulties, and we were doing some really lovely work. And I always felt that within session was like he would be able to ground himself. He would be able to create some connection with sort of soothe strategies, that parasympathetic, that calm, relax sort of state within our sessions. And that was within the therapeutic relationship. But then he told me one day that as soon as he leaves the doors, as soon as he's outside, he's back into the world and he's traveling towards a site where he was assaulted when he first came to the country, and it was a serious assault. And so every day he's traveling past this location that he can't get anywhere. He can't even go to the shops without being presented with this location. And so what happens is that because of the context in which he's living, because of the fact that he's held in state due to the difficulties of relocating within the current housing uh, processes that we've got, he's forced to be sort of held in stasis. He's held in stasis, and we do the good work, but we drop him back out into society where nothing is changing. And that was just a sort of almost a small obvious example of the problem that I see.
And I think I didn't appreciate that connection with trauma that a lot of people we work with before I started working in service. And certainly, how deeply rooted that trauma is, and understanding where, as pain clinicians, come in and what the remit of the work that we do is, and how far scoping that needs to be because of limitations in other services naturally, because NHS services are burdened and backlogged, and there is a real need for more clinicians like you to be able to step in and I hate using this word, but it's treating it holistically.
Yeah, I think the scope of practice question always comes up for me a great deal. I think we I think there's such a high degree of trauma within within society, but certainly within pain services. And I think I'm not necessarily talking about um, sort of PTSD, complex PTSD, although it is a very high representation within our population. Um, but I'm talking about maybe sort of ACEs scores. We would see pretty high ACEs scores in a very high percentage of our patient population. Um, and I think the question of how we manage trauma within our pain services is such a pertinent one, because like we said, what we're doing a great deal of the time is waiting on sort of trauma services, which have huge pressures, the gigantic pressures, and oftentimes what we need is for the thread of the trauma care, whether that's sort of an EMDR type intervention, that kind of processing work. But with that's the thread of the trauma care to run alongside whatever it is we're doing within the pain service, so whether that's a physiotherapeutic, like sort of graded exposure, or more, I would say, throw the doors open, say just an behavioural activation type sort of intervention process, where what we're trying to do is connect people with things of meaning and value in their lives, shifting towards sort of finding connection and love and pleasure, and all those positive things that we're sort of trying to steer towards. But I often will find the idea of trauma as being a real anchor to the ability to make progress. It pulls people back into their history, and I think particularly with the complexity of the physical nature of pain, it pulls people back to their pain, focused on their pain, and so we really struggle to disentangle the pain state and the disability that brings from the trauma context. Um, and again, that goes back to the social issue in this sort of circumstance, because I think the trauma is in society, right? It's sort of all over the place, and where those things are witnessed and experienced aren't necessarily within the therapeutic within the therapy room, where unless you're doing your trauma work, where you step towards that. But within society, it's coming from all angles. It's you are walking past the site of your assault. You are approached by the truck that tipped you as a child. You are surrounded by noise and press of people, and um, and it's unremitting. It doesn't stop. And so I'm always slightly amazed when people move the needle at all in these sorts of situations, because I think it takes a giant amount of um, courage and vulnerability, and you know uh, um, to actually start making changes in the life given the context.
It's really interesting. You talked about values just a moment ago, and it took me back to a few patients that I was working with that, came into the service and were certainly expecting this very medicalized model of care from us. And what struck me was actually, no, we're going to be talking about your values. We're going to be talking about expectations, and there seemed to be, not with all of them, but with a fair few, this disconnect within what they were expecting, and oh, I'm just here for an injection, right? And like, well, actually, there's all these other things that we can work on, in adjunct to the injection, sure, if that's what you want. But I wonder what kind of, because you've been working in the pain service far longer than I wonder what type of people or patients you've seen in terms of who's coming into the service, who's using the service. Bearing in mind we are located in London, in North London, so it can be specific to that region.
Okay. It's a it's such an interesting problem, because I think what I'm going to speak to first is the idea that we're almost constantly trying to disentangle um, our patients from a purely body-based biomedical perspective on their problem. And this is a problem of messaging throughout our healthcare system. I think what we do, or what we have done to create understanding, to sort of a cascade of diagnostic understanding, is to sort of anatomize the experience of pain. Anatomize to meaning to cut up and name. I love that. The idea that we have cut up and named this state, which is actually a bit of a misunderstanding of the pain experience. Where our pain experience is so three-dimensional and integrated, and so quite a lot of the time we're almost trying to reconnect scattered parts of the person to try and pull an understanding of themselves together, and to make sense of themselves, to make sense of what they're experiencing. And that's really complicated when you have a population, and this is to start to speak to the population that we have. We have a population who really believe that their pain is because of the structure in their back, and that is all. And there's all sorts of reasons why people have that notion, because they're told it to start with. They're told it by their GPs and their orthopedic doctors, and they're told it by their physios to a certain degree. And the alternative narrative isn't necessarily presented as keenly as I would like. I think quite often it's what happens is it's treated as a physical problem. The pain is treated as this biomedical problem until it fails. We can't treat this anymore. Oh, we can't deal with this problem. So we're going to have to deconceptualize the problem as sort of its essentially sensitized state, and therefore different. Whereas my perspective on pains, and I think our consultant says this: pain is pain is pain. And I think the idea of trying to separate it out as a bit more this sort of thing or a bit more that sort of thing, is always a little bit tricky. So I would say the messaging of pain needs to start way earlier, and bringing in the different contributors needs to sort of happen way earlier in the process, so right from the beginning within primary care, I would say. Which is really complicated, because that puts a giant time pressure on people. In the pain service, I'm super aware of this almost luxury we have with time, I suppose. But what we're trying to do with that time is create a paradigm shift in understanding, and that can just take the longest time. And I would say it takes the longest time, particularly within a North London pain service, because we have a really wide spectrum of different people coming into the service. We've already spoken to the percentage of people who are sort of traumatized in some degree, and that being an anchor for them. But I would say that there have a very large percentage, and I can't off the top of my head think of the exact percentages, but it's around 20 20 to 30% of all people that come in don't have English as a first language. I would say that the rather wordy ways that I create connection and create understanding within a therapeutic context is then sort of going through a step of translation, which I don't necessarily know exactly what's being said. I'm quite pernickety about my language, so there's different sort of difficulties in that respect. Um, and also, it's thinking about, well, what do I bring to the table in terms of my I have I'm a white Western cisgendered man. I have a particular sort of spectrum of needs to create self-esteem, to create security, to create connection, and so it's really looking at the capacity to broaden your scope of awareness of the people in front of you. And I think when we're dealing with very large populations like we are in the pain service, of people who there is difficulty within the context to just have a baseline communication, a baseline concept of what's going on. It's really tempting to sort of boil that down to sort of simplistic language and simplistic concepts, and so then communicating difficulties, sort of difficult sub concepts like what is it that your heart desires in the world? How is it that you want to orientate your life to steer towards this, this sense of heartfelt meaning? Because this is what we're doing. How is it that you can communicate that if, if like the sense is that I'm just some random white dude, well off with, nice shoes and seems comfortable in life. There's that immediate disconnect, and I'm super conscious of that. It's in every interaction.
And I think that reminds me of sort of when I came in, and even of sort of the social lens we all bring. We're able-bodied, where we're not objectively in pain, and we're talking to people who have experienced pain for a long time, and they're sitting there, and sometimes there aren't the words to describe what they're feeling, how they're feeling. And I think what you've touched on is this real acknowledgement of privilege and difference, and being aware of that, I think, is hugely important.
I think there's a danger within the sort of work that we do. Essentially, what we take a very very broadly. We take a sort of an ACT overview. The sort of it's awareness of the present moment, acceptance of the present moment, orientating towards values, committed action, cognitive diffusion to get rid of some of the anchors. So we've got this broad sort of direction of the service, and I will often use sailboat analogy or something like that. So sort of how is it that we can, set sail and pull up the anchor and sail towards our North Star. And I think it makes me think about there was a cartoon. I'm not sure if I can do this justice, but perhaps you can put a link to the cartoon or something. There's a cartoon of a person in the middle of a road, clearly broken leg, in a terrible state, and in the background a truck bearing down on him. And from the side, the therapist says, "Just take some committed action." and I'm like, yeah, I get that. It's funny because if it was that simple, if it was a matter of, orientate towards your values and take committed action, how to take steps towards these things, then people would do it straight away. It's super easy. We're all smart creatures. We're pretty clever creatures. I would say where the cartoon misses is it misses the concept of the person in the road not being necessarily being damaged but immobilized, but psychologically. So from a polyvagal perspective, that dorsal vagal is shut down state. Um, the, the idea from a change perspective, that pre-contemplative, I can't, I can't, I can't make, I can't act, and to say, to that population, let's do a thing and take some action. It can just feel like, I often think about, sometimes I feel like when I've said something, I may as well have bounced a ping pong ball off it's just not there's just no movement there. Um, and that sense of being ineffectual, can be quite profound. Um, and so thinking about that population, um, there's I'm always really careful to try and ensure that I'm not expecting them to be in a position where they can. It's not a matter of following some breadcrumbs and you're going to get your outcome. Is if you've got to be so aware of the context in which the person is experiencing themselves, um, and the shocking sort of lack of resource and support and um, uh, required in which to actually sort of start even picking your posture up and to hold a steady gaze, let alone sort of even contemplate the notion of what's valuable to you. Because that's really what we're working with so often. It's people who are so shut down that you ask the question, what is important to you in your life? What is it that you want to orientate towards? How is it that you derive meaning? These are really questions for privileged folk who can have the time and space in which to explore those notions. And so often we'll be met back by people who just don't know. I don't know what I want. I just don't want to be here and in pain and just suffering. Just help me, please. And that's what we get so often. And so thinking about the context of the pain service, we have a real difficulty with almost even getting to the point where our therapeutic process that we work with, which is one of values-based orientation, committed action, I would say the compassion-focused therapeutic sort of understanding and the physiotherapeutic graded exposure type processes. We need to get to a certain level. There's this space. We need to get to that certain level um, before those things can even start helping, which is why the trauma work is often really, really necessary. But there's still a gap. There's still a gap in what's required in these sorts of situations, and I would argue um, that the gap is within the community, is within the day to day experience of life, in the social context in which they're living all the time.
Absolutely. And even whilst you were saying that, I was struck by how for me that marks the difference between working in something like pain service rather than MSK. Whereas I enjoyed both equally, and I did, but there was that that nuanciation working in, is that even a word? I don't know. Um, working in the pain service where I came in very naively thinking, oh, I've got this huge psychology background. Sure, I can do this. And then when you're working with patients, and like rightly you said, like if you're trying to goal set or orientate values and they don't know, or they're not in a position where they can do that, you're like, well, what do I do? Where do I go from here? Like, I'm so used to being solution focused or goal focused that this isn't the same thing. anymore. This isn't the same way of treating. And I learned very quickly that it's the slow burn. It's the inception of ideas. It's waiting for it to grow. It's it's having the patience to sit back and be okay with the stillness of it. And often for me, that was accompanied by the frustration of it because nothing was changing, and and I felt responsible. Like, okay, let's get them moving. Let's get them doing something. Let's get them, let's change something, anything. When that wasn't happening, there was this, for me, this, like I said, this huge responsibility of, oh, I'm failing. And actually, it's exactly what you said. It's the waiting. It's the working in collaboration, and it's using the ACT principles. It's using therapy, the system team model. It's amalgamating all these different things to bring together. And yeah, I learned that lesson very quickly, um,
Yeah,
and I'm so glad I did.
yeah. I think the timing is so important. I think we see people in pain service in very different sort of readiness for change states, um, and I think sometimes we catch someone who's sort of just up on their surfboard and starting to go, and it's great because we can do all the things and it all works brilliantly, and the goal setting is seamless, and um, and you know we see people really fly. But then I would say that's not the norm. That's not the process. What we spend so much time doing is, well, it's outlining for them that the process that they're working on here is surfing in the first place. This is the game that we're playing. We're trying to catch a wave and convince them to start playing a game, and it that's complicated when they believe that what they should be doing is not surfing at all, is being picked up by a boat and taken to shore. Um, and so and so and so we wait, and we hold space, right? And we feed idea, and we cultivate a notion that they could be living their lives in a different way. We try and create a sense um, of wondering how they could live their lives differently. I think about the dream in this sort of situation. How is it that we can dream into a future differently to what we're experiencing now? It's different, and cultivating that notion, that daring to dream state is a risky little business. As a physiotherapist, honestly, scope of practice and art, careful now. But it's the same stuff, though. It's just slightly flowery language around how is it that we want the future to be different, and the fact that it's that one of the biggest stumbling blocks is that self-esteem is so low that there's almost a lack of worthiness of a better future in such large numbers of our population. That lack of sense of worthiness, of of deserving that things can possibly be or should possibly be better for them, that they could have a want, they could have a desire that they had to experience in their lives. Um, and that's complicated work. And so it's often done as I often think about it as seed sowing. It's seed sowing that comes after the understanding that we can understand that pain is a complex problem with lots of different contributing factors, and that what we're doing here is we're getting in a boat and we're setting sail towards a better life.
But what you've so beautifully said and talked about are all the different types of tools we use in a pain service. You've talked
Yeah,
about the acceptance and commitment therapy and values-based work, the passion focused therapy, the EMDR, all these different tools. I'm wondering what other tools sort of you use within that sort of pain service that exists. So I wonder if you
Yeah.
could tell me more
Well,
about those.
I I think um, one of the greatest tools that we have is I think one of the greatest tools that we have is being able to model a different way of being in relationship. Okay, I'm going to try and explain that a bit better.
Yeah.
Um, I think quite often people's experience of the world is cyclical, right? We find a certain way of being, and that's how we are. This is how we've always been. This is how we do stuff. But I often do a sort of a thought experiment with people. If you were to hover above yourself and watch yourself doing the things that you do in your day to day, you know, how quickly would it become incredibly predictable about exactly what you do and exactly what you do? It'd be really fast, don't it? I think psychologically we're pretty similar, and so quite often what I'm doing with people in the first instance is inviting them to think a little bit differently about themselves, inviting them to respond differently if to their body, inviting them to maybe respond differently to me as almost a rehearsal space for um, sort of how am I with another human being, full stop, right? And so we've got almost got like this rehearsal space in which to explore how a patient can be different, and that can be really stark. So, for example, um, I might have a patient who has a rather panicky response to certain movements. That so it's not just a pain experience, but it's a contraction or a flushing or a heart rate increase. So we've got this cascading sympathetic response, um, and oftentimes that patient will tumble into the end product of that sympathetic response, which is a panic. Within the context of a therapeutic room, what we can start to harness is slightly different pathways. So maybe we notice the first edge of that sympathetic cascade. Maybe we can catch it. Maybe we can strategize and ground and resource ourselves in that moment to connect to the calm, relaxed sort of state and continue with the action, and that's the notion of pendulation within the context of a therapeutic room is really easy. That move towards the threatening thing, but then being able to move back towards the safety. And so often that's sort of the fundamental basis of what I'm doing within the therapy. But it's a graded exposure process where we're pendulating towards that sense of threat, that sense of upregulate, perhaps that sense of pain, but then knowing that we can always come back. The pendulum will swing. The pendulum will swing back, and it's safe. So knowing, getting used to that swing, that used to that move towards and come back to safety. Knowing that pendulum swing is there is the basis of everything that I do, I suppose. With our last psychologist, she talks about everything being graded exposure. We laugh about it, but I don't disagree with that to a great degree. I think the so much of what I do is graded exposure. Obviously, where we're going and what we're doing has sort of orientation to it. So there's a lot of the orientation stuff that we do as well, which is sort of the act based values stuff and that kind of thing. And that is I suppose the other thing that we end up doing quite a lot of is how is it that we start to cultivate. How is it that we start to cultivate the deserving of a better life? And that's complicated. Because I think in the first instance, it's bringing people to a point of realization that their life could possibly be different. That's the first thing. Like, can your life possibly be different? And if the answer is absolutely not, I've got my pain. There's nothing anybody can do about it. I am how I am. Everything that's been tried so far has failed. And if that's the belief system in the first instance, then we need to sort of question that, and that can feel like a risky business, because what I do in these sort of situations is actually still the concept of hope for a better future. Yeah. Hope for a better future, that things can be different. Wow. That's a notion. That's a risky notion for someone with 40 years of fibromyalgia who's been only experienced this progressively disabling and disorientating condition. For me to say, look, in my experience, if we do this thing, then things can get better for you. It's a risky statement, because I don't know the future. How I can't just I don't know how things will unfold, and I don't have good statistics to say if we do this, then hey presto, we're going to get the result that we want. So there's a degree of courage involved from me, I would say, and from the person in the room to say, let's hope. Let's have some faith that things can possibly be better. And I would say I'm quite good at that.
I'd
That's a
agree.
skill. It's a skill that I've got. And it always feels like a little bit of a risky skill to have. But then it's defining what does better actually mean? I would say that next step along from creating hope for a better life, the next step along is how is it that better could be defined? And it's, is it that your pain is less? Is it that you're able to engage with the things that you love a little bit more? Is it that that you're getting dressed in more? How is it that you're defining better? And better being defined is, I suppose, the first sort of step. What is 1% better? What is the smallest fractional identifying feature of better that we can identify and that you can do? And then we go, look, you did something that made you better. How much better can you be? How much better can you be? Because you've done this one small thing. What is the next and the next and the next? And that small fractional change, when we've got someone who's made a small fractional change, the argument becomes simple. How much better can you be? And people suddenly go, maybe I could. Maybe this is possible. Maybe if I've done this thing, I can do other things. And that's what we do.
I mean, you say that's all we do, but I think, just to reiterate how hard that is and how well you do that, because I've seen you do that in my practice. And I've seen you do that not just with the patients, but with me, for example, with other staff members. You have this very innate ability to instill that hope and to instill that sense of, I can do it. And yes, there's this acknowledgement that it's hard, and you're swinging against the stream kind of, but there is that possibility, there is that chance that it can change. And I think as a practitioner, you are particularly skilled at doing it in a very genuine way, and not in a not in a very authentic way.
Well, I think you've nailed the word there. It's authenticity in these situations. I often will describe myself as the most hopeful therapist, physiotherapist. I have almost endless hope for people, and genuinely, like it's in my DNA, in my heart, my mind, and um, I I desperately believe that things can be better, and I want that for people, and that's carried in the therapeutic context, right? That right there, you think about transference and counter-transference. If I'm bringing a half-hearted, yeah, maybe you can get better. I don't know. It depends how much effort you put in, I suppose. You know, if that's my state, if like truly in my heart, that if that's the way that I am with people, then they pick that up. They pick that up. You know, the patient knows. Whereas I would say, you know, yeah, the authenticity of my hope is I suspect it's a little contagious, um, and it's almost that's part of the dynamic that goes on in the room, in sessions that I do, um, because it's so regular that I would say one of the things that happens within my sessions is people will say, okay, I really feel like there's hope for the future, you know, and that for me is a great outcome of the session. If there's that little bit of hope for a better future, then I know that we've got a game on, and we can do that thing. But it has to come back to the authenticity of the therapist in that relationship. And this is sort of part of the problem is that, um, I would say in MSK, I don't know that we'd even talk about, you know, our therapeutic interactions in this language. We wouldn't even necessarily talk about it because it's so process driven. We're doing the screening and clearing the red flags and ensuring that what we're doing is zooming into, the problem. We're very solutions based. We've got some nice sort of guidelines to direct us in our process. We give the prescription of exercise or the prescription of manual intervention. We're doing this thing, and it doesn't really have um, room to discuss sort of these rather these rather giant, um, ideas of hope and expectation. You know, I would say that MSK oftentimes, and I hold this as well in my history, is that I'm doing a thing with you as a physiotherapist with a patient, and you do these things, and I expect you to get better. Whereas it's being able to, um, I would say one of the big differences is really being able to shelve that expectation. Like my expectations is really pushed to one side. I don't expect people to come back and having done the exercises, because I know that that's a complicated notion. You know, I may as well be asking them to do backflips. Um, so I think holding back on expectation, but then really holding a strong, authentic hope for possible change is a good starting point for what goes on in my treatment sessions.
Absolutely, because often what happens and what I've seen happen is people get referred to pain services as an end of line sort of situation where it's either too complex or they've tried traditional physiotherapy and failed. And I put fail in quotation marks in case anyone is listening to this, because it didn't work. And actually, is it that, you know, it didn't work because the system isn't set up for it to work for them? Or is it the other way around? And then for me, that's where I felt this immense pressure. Because it's like, shit, what's after this? There is nothing after this.
Yeah,
And so we're holding a lot of that. Well, now you fix it.
yeah. And so often the referral comes in with exactly that notion. You fix them. Oh, oh my gosh. I'd quite like to read something.
Mm.
Um, I'm I'm just going to look it up quickly because it really um, encapsulates the notion of what we're doing. Uh, yeah, let me just find out who this was. This is a quote by Cherie Bliss Tilsley, sorry. Medicine Woman's Prayer. It's up on the wall in the room. I will not rescue you, for you are not powerless. I will not fix you, for you are not broken. I will not heal you, for I see you in your wholeness. I will walk with you through the darkness as you remember your light. I almost get a bit teary when I read that, but it encapsulates the sort of the notion of what we're doing so often is we're not fixing people in a pain service. You know, they've gone through the processes of trying to be fixed through through being given exercises, being given drugs, being given surgical interventions, like by giving injections, these things that are done to them to try and create this fix. You know, that's the biomedical bias, right? It's that I see the problem, I can boil it down to this thing, and I've got an intervention for you. What happens when all those interventions quote fail, right? And they're dropped on our doorstep, right? That's how they get to us. And so already we're coming from a position where the person feels like they can't be treated, yet at the same time they don't have a notion of how possibly they could um, uh, do anything different. And so what we're doing is we're stepping people towards this other way of working. You know? And it's oftentimes the notion from the poem there is that uh, what we're aiming for is to develop that sense of I'm not broken. My body is it's not necessarily it's not the damage in my body that's anchoring this. We use a lot of um, the explained pain literature developments there to sort of really understand their pain, sort of broaden out that understanding, and that's how we can start making progress in the notion of not broken. And then it's this 1% change that we start stepping towards this idea that you're not powerless. That those taking those, building the understanding and starting to take steps in the world, start building this sense of esteem that perhaps I do deserve a better future, or reconnect with people in my life that have disappeared, or things in my life that have disappeared. It's this sort of slow cultivation and build towards quote remembering your light. And I think the idea of that light being able to be just flicked on it's just not, it doesn't work like that. And then what I'll often say is that the therapy room, the physiotherapy room that we work in is the exploration of finding the light switch, finding I would say the dimmer switch that goes, we, we, we can be different. Life can be different. Um, and therein lies the problem, right? Because if we do that within the context of a therapy room, then chuck them back out into the world, then the light switch can be flipped off quite readily. So often I think about I think about the community problem. I think about the social problem, and I come back round to it, and round to it, and round to it as a real issue. Um,
And
yeah.
I can contest that that is something that you've been championing for a while now, and you can see that real drive there. And as you were talking, I was just struck with how there can be so many misconceptions of the people who access it themselves, who come to a pain service, where they can be seen, you know, they may be seen as not motivated or stuck or not willing to change. And actually, this group of people are incredibly resilient, are incredibly persistent. And I
Oh
don't
God.
think services or some clinicians, and myself included, maybe initially, give them credit for.
Yeah, I think that's profound. I would say that the patients that I see are some of the most courageous humans. Sort of keep just keep going. You know, they're presented with complexity and they've got a wide spectrum of issues, and they keep going. And there is an assumption. There is this. There is an assumption in lots of circumstances. It's the and I'm absolutely in. I have these responses as well. But it's the eye roll patient. It's the, oh my God, you know, why can't they just, kind of responses that I find myself having sometimes. But I've got a good scope on myself. I catch myself in those moments, and can pull that back, and remind myself that rarely it's rarely that people just won't. I just won't. Can't be bothered. Not doing those things. Can't be bothered. It's they can't. They can't do those things. And there's a massive difference between want. Yeah, can't be bothered. Like I can say today, my son Lucas, he won't do his piano practice. Yeah, definitely could. Right? Can't be bothered. Can't be bothered today. Want to play Minecraft or whatever it is he does. Right? Um, the can't state is a shutdown state. That immobilized state, and I always take a polyvagal perspective on this. Is I really like. I often will explain the polyvagal way. Um, we've got the dorsal vagal shutdown state, and the nice connective rest digest cozy state of ventral vagal, and then in the middle we've got we've got this middle portion where we could say drive and fight and flight, and these other states exist. And I would say part of the work as well to sort of think about what is it that we do. Part of the work in um, with patients is really drawing the awareness to the fact that they aren't in this continuous state. That change is constantly happening. That there's nuance all the time. There's good phases and there's bad phases and terrible phases, but there's slightly less terrible phases as well. You know, and even though you might define yourself still as terrible, there's magnitudes of that. So there is movement. There's always movement. And so harnessing that notion and starting to get people to notice that notion of this sort of constantly changing um, sort of experience of themselves, it is a really good starting point. It's again thinking about the addition of that 1% small change in their life. You know, if they notice that, wow, changes all the time. I wonder how much change is possible with my gloriously neuroplastic nervous system. How much possible changes is there to make my life different, right? And so I think that notion, that very mindful notion of noticing change is pretty key.
Yeah. And I love that even after like 18 months of working with you, you continue to teach me things, and genuinely I've talked to other people about how the work that you do inspires my work and the work that I do. I'm wondering who inspires your work? Where do you sort of
Oh gosh, yeah, no, that's a really good question. I think I've read broadly about. I would say that a lot of my orientation and underpinning in terms of theory base doesn't necessarily come from the sort of the physio types, but of course there have been some glorious physio types in the world, and we have our Louis Gifford with it, which was my my first sort of orientating in terms of understanding of the complexity of our pain experience. If you haven't read Aches and Pains, go read Aches and Pains. It's beautiful. It's really accessible. It's enough work, good language the whole way through. I love it. So Louis Gifford was early. And then, of course, we've got the Lorimer Moseley and David Butler, and that I think they really encouraged a sort of a growth in awareness of uh, um, of how we can start communicating these difficult problems. I think moving away from the uh, the sort of the more physio types. I would say the polyvagal theory. I've read Bessel van der Kolk's Body Keeps a Score. I think was profoundly important for sort of text for me. I would say that I've expanded that and read quite a lot of Stephen Porges's work. And I love Deb Dana's language, and that pops up in the clinic room around. She uses the terms glimmers and triggers instead of sort of sims and dims. So I'll often sort of use her language within the clinic room. I would say that even I would say people like Brené Brown, who have had sort of her work in understanding the braking systems that people have, around deserving of love and belonging. I would say that underpinning sense and cultivating this sort of sense of deserving of love and belonging is it's a notion that I hold in my mind a great deal, and that comes from Brené Brown's work. I would say conceptually, I've loved. There's a book called Transcend by Scott Kaufman, who sort of reconceptualized the Maslow's hierarchy of need and put it into a sailboat analogy, which I would say is a manner in which I think I could talk about that quite a bit, but I don't think I will today. But that I think that's really lovely work. And then more recently, it's actually James Maskell. I read James Maskell's The Community Cure and started moving into sort of that rather broader way of looking at how is it that we could possibly intervene with these complex social problems. And I think that's a really important bit because it's starting to move away from one-to-one treatment into a notion of far more group-based, community connection-based sort of processes. And that I would say James Maskell's work that really triggered in my mind. How is it that I'm thinking about how an evolution of a pain service has to move, because it has to evolve. I think that there is an evolution that's necessary because what we're doing within the services is so often we're creating a container in which they can change within this context. Then we might be able to step them out to like a pain management program or some group exercise where they can now in this next context we can feel safe. But then there's nothing that goes back into the community, or they're very little. We have some examples. We have some examples of we've down in Dorset with the Chatty Cafe, and I find that really inspiring. I think that's been cultivated beautifully, and I think there are certain services that have looked to create these social support systems on discharge. But I would say it's almost a little bit more than that. I would say the idea of the community cure is is such a profound notion in my mind, and how do we generate that in a system that seems to bias um, curative intervention over prevention. You know, the preventative. What are the preventative steps that we could take, that we could possibly use in order to create a society where this is a bit utopian, but I'm going to go with it. Where we really bias the cultivation of love and pleasure and connection. How is it that we can create that? That's what I'm into.
That's so beautiful. That's so, so beautiful. Um, I'm wondering, because, I lecture at universities, and often, what I get asked is, well, how do we get into this? How do we, and not just students, but other practitioners as well. What would you tell other practitioners if they were interested in pain, apart from the lovely reading list you've already given us? How would you suggest, how would you suggest to them how to sort of get into this type?
You know, I think it's I'm what what I really notice about people who end up in pain services and doing this sort of work, um, is that you kind of need to know about yourself, that you, on a heartfelt basis, really care in this really broad manner, really care, this broad manner of about people. Um, you need to care about society. You need to care about inequality. You need to care about the world that we live in. What you know, if we zoom in too much, if we zoom in on the individual too much, and the clinical too much, then we kind of lose we kind of lose some of the heart that's necessary for the work. Um, and so in the first instance, I'm like, cultivate the caring. What is it that you really feel passionate about as a human being? You know, what is it that you want from this world? Like you as a therapist, you as a physiotherapist, you as an osteopath, you as a psychologist. What is it that you want for this world? What is this utopian picture that you would want to move towards? And then what action are you willing to take to move towards that?
Hmm.
You know, that's a notion which is complicated because like little sort of human in amongst the millions of people and the giant problems in the world. But I think we need to orientate ourselves. What are we doing? Why am I acting in the first instance? Why is it that I want this person sitting in front of me to have a better life? Is this a paycheck thing? Yeah, well, a little bit, sure. I've got good at a very specific thing, and which is tricky. But it is. I make money back, there's a degree of calling as well because I really want things to be better. You know, I care about the world. I care about the people in it. And so noticing that in yourself, I would say in the first instance, is really cultivating that sense of um, caring for the world, and what is it that how is it that you want this to be better, and that takes you on the path, that puts you on the path, it gives you your north star. Because if it's if the reason that you're going into therapies is to fix people, that's cool as well. That's great. There's all sorts of different sort of arenas in which you can practice like that really effectively as well, because there is a population who connect with that, can be can be fixed, and symptoms can be modified. Great, absolutely great. There's plenty of patients around for absolutely everyone, right? And so if you're a bit more that way inclined, then and I like being solve the puzzle and to fix the thing and they'll do the thing and hey presto, they're touching their toes and better in the world. Great. But I would say that possibly a pain service isn't going to tick the box because it's really taking it's taking us we're taking us a different path. We're on a different route. If the problem that we were dealing with was that simple, that we would have seen that well, they wouldn't be here and I wouldn't need to exist. And so I would say you know what kind of therapist you are, know what kind of person that you are, and I would say non-judgmentally. By the way, I don't. There's room for everyone.
Mm-hmm.
Yeah, and there's room for all the different therapeutic processes. But knowing what kind of a therapist you are is, I think, the start. And if you do have this sort of real heartfelt response to wanting to create change, well, that's a really interesting thread to pick up because you might be a good pain therapist.
Yeah, and I have to say there are some really special individuals in our team who embody that, and and that's what I'm drawn to, and that's what I get excited about. And, my favorite part of the day is when we touch base in the morning, and that's and that just sets you up for the whole day because you have that sort of infectious type of energy about you. Now, inevitably, I always get asked questions by people when they DM me after the podcast was released, and I'm very conscious of how limited my knowledge base is. So, where can people find you if they have questions or they want to get in touch, or where can
Sure.
people find you?
I'm very, very happy for people to shoot me an email. Shoot me an email at my email address is archerphysio@gmail.com.
Yeah.
So those contact details are all fine.
And I'll put all those details in the description box below so people can sort of find you. But thank you for talking to me. I've been looking forward to this for so long, and I've just I mean we could just talk for hours and hours.
Yeah.
And that's the beauty of just being around you. So thank you so much.
I honestly, I really enjoyed this. This is really cool. I think I wrote notes. I actually got everything in my notes, so I'm absolutely thrilled with what we've covered today. So thank you so much for giving me this opportunity.
Thanks so much, Mark.